All right, this is part two, or for the Parkinson's disease. So if you have not listened to part one yet, I don't have them labeled as that, but the first one is the Parkinson's drugs, and then this is a second one, just going a little bit more to the specifics of first line, second line, etc., kind of approach the patient. So please listen to that other one first if you have not, and then come to this one. So having said that, let's just get into it. This is the pharmacological treatment of Parkinson's disease. So we can divide this into three things: surgical, pharmacological, non-pharmacological. For testing purposes, for me, pharmacological is what we are going to stick to. PD is the abbreviation there that we'll be using throughout this presentation. But then that's so the treatment of the pharmacological treatment has two subcategories. So that's neuroprotective and symptomatic therapy. So the neuroprotective is a therapy that's supposed to hopefully help protect the brain and help protect the progression of the disease. So there's some strategies there that you can employ. And then the symptomatic therapy is going to be, it's like palliative therapy. It's treating the symptoms. So a patient, the disease has already progressed, and it's their treatment, their medications that don't necessarily prevent the treatment from progressing. Rather, they help treat the symptoms. So majority of all the available treatments are symptomatic in nature. Unfortunately, there's not a lot that slow or reverse the natural course of the disease. So there's definitely, it's an area that's being studied. There's new drugs coming out all the time. So just kind of stay tuned for that. Maybe in y'all's lifetime, when you're practitioners and stuff, you're out there prescribing, they'll probably come out with some new therapies and stuff. But they're definitely trying to get to where there's more neuroprotective therapies. But for now, symptomatic is what you guys are going to be dealing with. So with the symptomatic therapy, these are some bullet points here I'd like you guys to just look through. This is going to help you guys determine when to start using these medications. And it's really patient specific. It's going to depend on your patient and their specific symptoms. And then how much impairment is it, on their work, ability to get around, day-to-day activities, etc. Major drugs here, we talked about these all before in the previous lecture, so please go back and look at those. But here are the major drugs and categories. So first line for most of your patients is going to be the levodopa. It is very effective for the symptomatic treatment, especially the bradykinesia, which is that movement disorder, but it's a slow movement disorder, or there's slow movements. Brady means slow, and the kinesia means movement, so it's a slow movement. It can also help with akinetic symptoms, so that's something else and it can be used in combination. We noticed that I note that they make double pills. They make combinations of two things and with three things. They can be used as monotherapy or in combination. It's going to really depend. Usually early on, they do stick to monotherapy, and they try not to get the drug burden because of adverse effects. So the more drugs you add, and the more that you're affecting the dopamine, you remember from previous lecture, more chance of those adverse effects with the dopamine. So that is something to think about. Dopamine agonists can also be employed either as monotherapy or early on in the disease, or a combination with a more advanced disease. They are ineffective in patients who show no response to levodopa, though, so that's something to think about. And they may delay the need to initiate levodopa therapy. But then they also have the problems with impulse control disorders. They have their adverse effects to think about as well, and those can be pretty problematic. So either the levodopa or dopamine can be initially used, and it's just going to kind of depend specifically on your patient. So I don't want to read all of this to you, but just know that there sometimes is age consideration, so make sure you look at that, depending on if the patient's older or younger than 65. It also depends on how early the disease is, regardless of the age of the patient. So earlier in the disease process, you may want to not use levodopa. So that's just go ahead and read through those, and the MOB inhibitors as well. Anticholinergics can be useful monotherapy, typically preferred in non-elderly patients because of the anticholinergic adverse effects, which we talked about in other lectures. So definitely those are that can be a deterrence, especially for older individuals, because of that. Amantadine is another one too that's so typically used in helpful with younger patients with mild PD. And again, watch out with older patients with amantadine and anticholinergics, and because of the toxic side effects. Therapy should be individualized, so put a star by that, highlight that. This is just kind of some guides of, what can help. And again, just some kind of general, like I said, anticholinergics avoid in the elderly population, especially as monotherapy and especially, by itself or higher doses. But, lowest doses usually, so start low, go slow if you can. Usually try to start with monotherapy if you can, but it's going to be a very highly customized approach that you're going to have to take with your PD patients. Summary recommendations, just go ahead and read through these. I'm not going to read through these for you, or with you rather, but go ahead and just read through those. And that is the end of my presentation. So hopefully that helped a little bit. I know it isn't great just because it's not a clear-cut, straightforward, like, here you go, boom, like 1, 2, 3, this is what you do. It's just some guides. You have to think about adverse effects, the age of the patient, how far the disease has progressed, etc. So anyways, as always, email me if you have any questions. Thank you guys for your time and information. I mean, time and, I didn't mean to say information. What was I trying to say? Time and attention is what I was going to say. So thank you for your time and attention, not your information. But yeah, email me if you want. Talk to you guys later. Bye.